The relationship between addictive behavior and prescription pain medication is a really complex one. It's something that is often hard to predict, or actually almost always hard to predict. There are some predictors that have been shown in the literature, like obviously a previous history of substance abuse or potentially a family history of substance abuse, maybe some underlying psychopathology, but it's something that is very hard to address, and I think that prescribers and dispensers share a very difficult role in it. We're trying to be caring clinicians and treat our patients with pain, but also because of all the issues legally that we're faced with, we have to sort of be these policing investigators too, and it can be two very difficult roles that are hard to consolidate. Wow, okay, so some of the conflicts that arise. Pharmacists are faced with a great deal of challenges in the community especially because we're faced with many ways that patients can present fraudulent prescriptions and many ways that they can participate in drug misuse, abuse, and diversion. And if we as pharmacists don't do our due diligence to make reasonable inquiry into these prescriptions, we're faced with a great deal of liability, fines, loss of licensure. And so what happens is pharmacists may be perceived as being hypervigilant or unnecessarily vigilant in verifying the validity of pain therapy and prescriptions, and that can be faced with a lot of barriers by prescribers. And I understand this quite well as a prescriber. I'm also faced with barriers from the pharmacy side too. So it's a difficult dance that we share in trying to ensure access to care for our patients and also not contributing to drug abuse, misuse, and diversion. And I think that if prescribers and dispensers just talk more and come to terms that we share patient care together and get, for example, if you're a physician in your community, getting to know your local community pharmacist, I think that that can really go a long way to resolve some of the problems and ultimately end in better patient care. Well, as a prescriber, self-escalating doses is one of them, and it can be a big indicator or it can be a minor one depending on what the cause is. If it's uncontrolled pain, maybe there's something else that you need to look at other than just worry about addiction. But doctor shopping, pharmacy shopping, using our prescription drug monitoring programs that are state-specific can help with that. Also, lost prescriptions, I've had to deal with that. Things coming up on a urine drug screen that aren't supposed to be there, or things not showing up on a urine drug screen that are supposed to be there. Those are all things that we can use from the prescriber side to help identify potential addictive behaviors. And then from the pharmacist perspective, some of the red flags that we look for would be patients who are perhaps traveling a long distance to the pharmacy, because that could be that they're driving all over the place, pharmacy shopping, filling prescriptions off of a third-party payer, so cash prescriptions, large quantities, certain combinations of medications are red flags, like Norco and Soma, for example, along with other things, patient demeanor, and there's other things like just not knowing the patient, them not being a regular, that can prompt you to inquire further as to whether or not their use is valid. But all of these things, we have all of these tools as prescribers and dispensers, but you have to take them all for what they're worth. For example, if we run a prescription drug monitoring program report and we see that there's multiple prescribers on it, from the pharmacy standpoint, you can't get too worked up about it. You have to see, well, maybe they're all from the same group. So everything has to be taken for what it's worth, and I think that that's why places like PAINWeek, for example, are so amazing. There's so much education that's needed among providers to understand the little nuances in pain management, and to not put up barriers to our patients, and not enable them to bring harm on themselves at the same time. That's really tough. So as far as prescribers and dispensers helping patients deal with denial and recognize addiction in their own behaviors, I think that it's a really big challenge, because people who suffer from addiction, or maybe if they don't fit the criteria for addiction, maybe they're just on chronic opioid therapy and have been for long term, they often don't have, or most of the time don't have, insight into their lives, or what type of risky behavior they're going, or how their behaviors or the medication they're using has negatively impacted their lives. And I think that providers on all fronts can help patients to understand, or to help them have insight, or to help recognize these harmful behaviors, but it's very difficult to make someone realize the harm that they're going under. I think that everyone has to have their own light bulb moment, and I think for different addicts, it's different times, different places. Wherever their low is, wherever their turning point is, wherever they have finally found the shame or guilt in something that they've done, I think it's different for everybody, because some people may never have that moment. What I'd like to pass on to our primary care audience is that pain management, especially chronic pain management, and also addiction and the deaths that have been occurring over recent years for from prescription drug overdoses, is something that requires attention and immediate attention, and that I think that it's everyone's job in healthcare to do their part to educate others, or get educated if you're not, and protect yourself and protect your patients as much as possible. We all have learned the Hippocratic Oath of doing no harm, but at the same time, we always want to offer clinical help. So get educated and do your part in every possible way.